Standing, I think, and we're going to continue with Dr. Joe Buyske, Associate Executive Director at the American Board of Surgery, and as of today, the President of SAGES for this year. Dr. Buyske is going to be discussing a little bit of a shift from the role of simulation in teaching and going to be discussing for us the use of simulation for certification.
So I was pretty pleased with this as a topic because we talk about this all the time. It seems like simulation should be an obvious way to test whether people are capable of being surgeons or not. We should have a model like the one we just saw and be able to put people through their paces and grade them and pat them on the back and send them on their way. My only disclosure is that I'm a salaried employee of the American Board of Surgery, which gives me the expertise to give this talk and might also make me prejudiced, up for you to say. So the official title I was given was Simulation as a Tool for Certification. Are we ready? And my first reaction when I got it was, nope. And we're not. So let me talk you through that a little bit and also throw down the challenge, because we should be and we will be in 5 years or 10 years. We're just not there yet. And there's a lot of work to be done along the way, and there are probably people in the room who are capable of doing at least some of it. So until last year, the requirements for certification for the American Board of Surgery were pretty basic. You had to finish an ACGME accredited residency, which is why it's impossible for people who trained in other countries to ever become certified by the American Board of Surgery, whether that's correct or not. You have to spend 48 weeks every year for 5 years doing clinical surgery. You have to do 750 cases in various required arenas of surgery. You have to have a signed letter from the program director saying that you're ready to be board certified. And you have to take a written examination and pass it. About 85% of the people who take it, 80 to 85% do. And then you have to take an oral examination, and then you're done. It's actually a fairly small list, and there's a lot of black box in there, and there's a lot of room for soft interpretation. 750 cases. What does that mean? What were you doing in the operating room? You were the surgeon. You were the first assistant. Who defined that? We didn't really say what that is. The program director attestation, based on a bunch of summative evaluations from attendings who may or may not have been particularly attentive during your time on the rotation. So there's a lot of gray area and things that we haven't really measured along the way. So we recognize that. The oral examination, those of you who have already taken it probably feel the urge to get sick when they see these pictures. Is in fact a simulation, a low-tech simulation. Cases are presented, they morph and change according to some of the responses. It's very similar to the computer-generated Bayesian matrix scenarios that are put out to test judgment and decision-making, or to teach judgment and decision-making along the line. So we have used simulation for a long time, just not the sexy simulation that we're seeing here and talking about. The logistics of certification are complicated, and so as we think about how we could use simulation to fulfill some of the measures or metrics of certification, let me just talk about the final step of certification and what goes into it right now. We test 1,200 people a year, of which we certify about 85% of them. We do it 5 times a year in 5 different places every year, in fact. There are 54 people giving the test every time, 6 people for every candidate. Every exam takes 90 minutes, and the whole sequence lasts from Sunday to Wednesday. I don't think there's another piece to that. So the number of variables that have to be brought into place to establish any kind of standard simulation, so 54 examiners for every exam, every one of them would have to know how to use a simulator, what all the metrics are that have to be tested and trained on that. If we're going to use this model, and we don't have to, we can blow everything up and start all over again. So if we're going to start using a new simulation technique, it's got to be universally applicable, something that we can all agree that every single surgeon needs to know how to do. We had a discussion this morning. Does every single surgeon need to know how to use a robot? Is that something that should be required of residency training? Maybe, maybe not. It should be mass-produced, something that can be made available, some device or mannequin that can be made available widely, replaced when broken, purchased multiple times over. It has to be affordable, has to be widely accessible, has to be a reproducible metric that everybody can do. Those 54 examiners, 108 examiners, over and over again, different parts of the country, different places. There have to be defined measurement metrics with pass points. There are a lot of simulations out there designed for teaching, but not for measuring, so that you can learn along the way, but there's no pass point to it. There's no, this is the standard at which you are now competent, and this is the standard at which you are not, and it has to be validated. So those are hard standards to actually reach. A few metrics or a few tools are available, and this year, for the first time, everyone who's a resident is required before applying to take their written examination to have passed ACLS. Surprisingly, that wasn't a requirement until this year. ATLS, which actually hasn't been validated but is so broadly accepted that we accept it as well. And the gold standard generated by SAGES, the fundamentals of laparoscopic surgery. Those are the new requirements for this year, and one that does not require any simulation, which is just a new distribution of cases. But those are 3 simulation tools that we're now using for certification. They all meet the requirements that I just mentioned. So ACLS, simulated resuscitation on a mannequin after a didactic course. ATLS, same thing, simulated resuscitation. And FLS, of course, simulated deconstructed skills that have been proven over the 12 years of development here at SAGES to be validated, reproducible, affordable, accessible. So what we need to do for any new tools, we'd have to think about where exactly are we going to use them. Are they going to be part of the final examination, the one that I just described, the one that takes place all over the country? Maybe, maybe not. Maybe there should be a single test center. Maybe we should build a building in Chicago like the orthopedic surgeons did and make everybody come through there to have their big simulation day or their big simulation week. Maybe they should be portable. Maybe it should be simulations on computers, on laptops that we can carry around the country. Maybe they should be at ACS accredited centers. They should be locally. When should they happen? Should it be a final exam that's done when you're done with your residency, done when you're with your written exam and as part of your oral examination? Or should there be milestones along the way during your residency, which is what ACLS, ATLS, and FLS are now? Maybe that requirement for certification should be pushed back down to the local level. Simulation that's managed within your residency program or managed locally, again at the ACS centers, or one in every city, or one within 100 miles of every resident, or something along those lines. And then the last question is who would administer the exam? If you do it during residency, it might be the program directors. Can they manage that burden? Would it be the program coordinators? FLS doesn't require a physician mentor or a physician proctor. You can train a layperson to do it, and that's one of the critical distinctions of allowing us to employ that particular metric. Does it have to be directors of the American Board of Surgery? Does it have to be physicians? Who's going to administer it, the simulation, and who's going to monitor it and proctor it? So there are a lot of obstacles to it. I sort of throw them out there, and yet I think that it's more a checklist than a list of obstacles. It's a checklist of requirements for what it is that we're looking for the perfect metrics. We found 3, and they were pretty easy. They were the low-hanging fruit. We're fully expecting fundamentals of endoscopic surgery to meet the same criterion, and we're sort of looking for things to fill in the other gaps. And it's not just about technical skills. It's not just about how to do operations. We're interested in simulations that measure judgment, clinical scenarios. But again, it has to be a right-wrong answer. There has to be a fail point and a pass point. We're interested in simulation for assessing professionalism, for assessing systems-based practice, team learning, patient safety, any of those things. Those all could potentially have a role, and I think probably will have a role in our lifetime. Our limitations, the board itself is not a research organization or development organization. We have 3 full-time physician staff and a whole bunch of coordinators. So we rely on other groups. In fact, we have occasionally given grants to other groups like Gary Dunnington at Southern Illinois University to develop metrics that we might be able to use. Our exams are high stakes, which means that we can't suddenly turn around and say, this year you're going to have to pass a whole bunch of simulation exams. Last year you didn't have to. So we have to phase things in slowly and balance them against each other and validate them as we move along. Any new requirements have to meet all of the listed criteria, the ones that we talked about before, and they have to address a real need. No simulation just for simulation's sake, because it's sexy and attractive and because there is a tremendous amount of pressure to start to employ it, but because it actually measures something that matters. And the final message is that we're looking for those tools. I think that there's the capacity within SAGES and some of the other professional societies to help us to develop them. And I think a lot of them are close, but all of the requirements that I listed have got to be met. So I hope somebody rises to the challenge.